open it up to some questions.
Hi, this is Steve. I guess I didn't have a chance to talk enough before, so I'll ask a question now. So this is for Peter. It's about the media. I think some of the problems you noted with the coverage is because of changes in the publishing industry, and the one of the problems is that science journalists who are knowledgeable about science are expensive and rare and are being cut left and right. The Washington Post science staff has been eviscerated over the past few years. So the difficulty is you're dealing with beat reporters who are, reporting on, down trees in the morning and and break-ins and science stories in the afternoon. And the sort of the scientific sophistication is constantly being pushed down, down, down. And it's almost impossible to spend enough time with these reporters to correct what's really just a miserable science background. There are a few sites and publications that are beefing up, finding a vacuum here. But for the most part, with New York Times perhaps accepted and a few others, we're dealing with a much less science literate news crew and news organizations that are not willing to support them to be educated. That is, it's hard to even get them to come to a conference or a class or anything. So so this is a huge sort of economic force that's going against science literacy in the media. And I'd just be interested in your thoughts about how we deal with that.
Yeah, I agree with your summation of the background forces. Where I'm not so sure, in terms of my own opinion, is that we need that education, in terms of science-based education, understanding, statistical principles, at least basic understanding, that's the solution. And in the spirit of, so to speak to that point for a second, some of the Washington Post story, he's not a science person. Some of the good, I think, science and health journalism stories come from business journalists or other journalists who go, I don't get it, that doesn't make any sense. And so they have basic journalistic principles that aid them in asking dumb questions, rather than, oh, it's a doctor, it's the CDC, or it's FDA, it must be true. And I think so in that sense, that's why I'm not totally convinced that the solution comes in a massive sort of educational reform of journalism approach. The other bit, which also leads me to the same conclusion, is that you see, I think scandals still sell. I think they really do, and that's why you have so many comments, and that's why some of these real, neat stories. Katie Thomas in the New York Times, she's a business, she's not from health. She doesn't have a science background. She was doing sports before that. They can latch onto a story and get a huge splash, and that's the currency, right? Is which page are you on, and how many people read it, and so I think that if you do enough of this, people realize, gosh, we got to get the next big scandal, because there's a lot of notoriety coming out of it. We win awards by doing it. So in that sense, it can be those minorities that can start to reform the field and realize science is not all about the white coats and whatever comes down from the top. And I think actually that the AIDS generation ruined us in that perspective, in that journalists started to see themselves as being able to save lives if they could just translate the message and get people to do what the scientists and the public health officials knew what was right. And so if they take themselves out of that role and get back into questioning and they get these big splashes, I do think there will be rewards for that. So there's the long haul approach, which is education, and I agree that's important, but I think there's ways around that, and that's, I think, where we have to, because that's such an expensive and timely and sort of almost impractical approach, we have to think about both. So that was a bit of a monologue.
Yeah.
I won't do that again.
My name's Marco. Kind of a follow-on to that question. I think I think you're right to a certain extent, but are you familiar with native advertising?
Native?
Native advertising?
No.
Or advertorials? Or
Yes.
paid content?
Advertorials, yes.
Right. Well, native advertising, if you don't know, it's one of the it's a new phenomena, and it's growing by about 20 to 30% a year. Last year, the New York Times main editor, I believe it was Blumenthal, Eileen Blumenthal, was fired because she opposed native advertising. As more of the print media is going digital, because they can't get enough advertising dollars for their print, they are having to rely on paid advertising, but a little bit more sophisticated paid advertising. So now companies, pharmaceutical companies particularly, because that's where the money is, are paying an awful lot of money to the New York Times, the Washington Post, Forbes, and Time Magazine to have their writers write pieces that are essentially infomercials in a very sophisticated way so that it looks as if it's an editorial, an authentic news piece, but in fact it's a paid advertising for a company. So regardless of whether that journalist is young, poorly informed, good intentioned, he or she is basically writing an advertisement. As to the other point about whether, your point about scandal still sells, maybe and maybe not, depending on how much money that company, that Time Magazine or the Washington Post, is getting for those paid advertisements. So there might be a wonderful scandal there. A reporter might be more than glad to write it, but then he writes it, and then it gets killed. And as you know, this has happened in the case of, say, Cheryl Atkinson, who was around for 20-some years. She left because a lot of her stories were simply not being published. So how do you address that phenomenon?
How do I address it? This will be a short monologue. Ideas? If you can document them, you can write them up, and you can publish, right? So you can at least plant the seeds of the documentation behind the story that you're talking about. The advertorial question, I just wanted to clarify, they're not indicated as anywhere, different font, nothing?
There is, go to YouTube and look for John Oliver and, John Oliver,
HBO.
Yeah, and he did a piece on this. And the problem is the CEO of Time Inc., I believe his name is Joe Rip, last year was interviewed, and he basically said, look, I see nothing wrong with this as long as the consumer knows the difference. And what Oliver said is very much on point. They've done surveys where it's very clear that the vast majority of the readers cannot tell the difference. So you're basically fooling the public, and you're getting the writers to write in to basically camouflage, essentially. And
Right.
we don't know what we're reading.
Right. I mean, I don't have solutions. You can think of some on the top of my head. You can have journals which say, it's almost like GMO in labeling, we don't do this. And so then the onus is on the ones that haven't made a statement about whether or not they do that in clarity. So you can raise more awareness of the issue as a starting point, perhaps as an idea.
This is a question for Lily. I really enjoyed your presentation. I thought it was, it's vital that we actually start compiling this type of information because people are asking about it all the time. And what I wondered was when you were doing your interviews and you were talking about the different types of engagement that they had for patients. I mean, some of the projects at PCORNet require actual engagement in a partnership type fashion, as well as things like advisory panels or focus groups. So, what my question to you is, when you were doing the interviews, did people say that one type of engagement proved more effective than another?
Thanks for that question. And that was something I really wanted to look at because I think when I began the project, it was before the engagement rubric came out, which is one of PCORI's I don't know how to describe it. It's sort of like a handy guide to engagement that researchers might rely on in planning engagement. But I think a big question in the field is which approaches are good for which outcomes and what are the best practices, because we just don't really have that information. I only had a sample of 19 projects, but I think one of my tentative conclusions is that it didn't seem that any particular approach was better or led to a certain outcome. I think maybe we've been focusing too much on which approach to use, a focus group versus an advisor group, when really what we need to be focusing on is how researchers respond to patients they engage, when they engage them, like if patients actually have involvement in decision making at key points in the research. And some people have looked at my research and said, well, I feel like you're asking the wrong question. Shouldn't we look at engagement before PCORI is even funding these projects? Like, or, who's driving the agenda? And I think that's also an important question, but a different question. So I think maybe I do think we need to learn more about which approaches seem useful, but I think maybe we've been focusing too much on approaches. I don't know if that answers your question, but thank you for that question.
I'd just like to make one follow-up comment on it. I was involved with working on the patient engagement rubric, which I think is a fabulous tool. And particularly if somebody is interested in applying for funding to PCORI, essentially you take out the patient engagement rubric and you say, where have I managed to get my engagement all the way down the road? So I also suspect, your study was done early on.
Yeah.
I suspect that there are going to be changes over time as these practices get more incorporated into the funding of grants.
Yeah, I think you're definitely right. It's sort of a moving target when it comes to patient engagement. But the engagement rubric came out as I was just finishing my interviews, and one of the researchers said, oh, I wish I had known this. I would have done all these great ideas that I never would have thought of. So I agree with you. Thank you.
I think in the back there was a question.
Yeah, and then, no, then me, and then, yeah, I had my hand up. You can go first.
Can you? I just wanted to just quickly come back to the debate around journalism. Speaking as a former journalist, because I'm the head of communication for Cochrane, the Cochrane collaboration. This is something we face all the time. And yes, there's loads of problems with the state of journalism and where it is now. But the one thing I would say is that it's also a huge opportunity for everyone in this room, because more and more journalists don't have time. The biggest pressure they face is time. So if you can give them the information that they need in a quick way that they can understand, it's actually, there's more and more of an opportunity for everyone in this room to get that information out, as long as you understand what they're looking for. So using it, basically, you better be able to say it in one sentence or they're not interested in what you have to say, honestly, because they have to convey that to an audience. And I wouldn't want people to kind of look at all there are lots of problems, but there's also a really big opportunity now because of the way journalism is now, and other sources of communication as well, to reach out much more widely than you might have had in the past, that alternative sources as well. So I just hope that you all really think about that in terms of that dissemination, because there's an opportunity with online. People will find what they want, and being able to search for things, they'll find the news media articles. So it is important to really make sure that's accurate, but there are lots of ways to do that now that maybe we didn't have in the past.
Yeah, thanks. There we go. Stephanie, could you talk a little bit more about implementation as opposed to dissemination? I'm on the PCORI board. I know that we have a lot of discussion there, and dissemination is much easier to figure out how you do if you have some good results to a clinical trial or whatever. But implementation, actually getting the physician or the patient to use the information, is much more difficult. And so I'd really love it if you would say, this is how ARC is going to do with results. How we're going to move to implement results.
I don't know that I have the answer for you, but I'll tell you my thoughts on it. So you're exactly right. Dissemination is much easier. It's the philosophy, if we build it, they will come. Only thing is we've discovered they don't always come. So, and we shared these preliminary ideas with some key leaders in implementation science. And the thing we've consistently heard, so I don't know how this is going to happen, but the thing we've consistently heard is for implementation to work, you really need those who are on the ground, who are involved in the healthcare system, to I don't want to say buy in, but really that has to be something they want to do. So it has to come up from below. So so the kind of top down and somewhere we have to meet between the top down and bottom up. And so I think that step, although I boiled it down into one box, I think that's going to be a lot more complicated. It's going to be messy. It's going to need a lot of back and forth in terms of discussions with people on the ground. What are they doing? How can it be done? And how can they do it? So I think the implementation, like I said, it's we're working it out still, but I think it'll have to involve grant mechanisms where the people who are wanting to do it will be the ones to propose projects to do the implementation.
But you are going to be undertaking to oversee implementation.
Yeah, that's our goal. That's
Okay,
our idea,
good.
that it would involve. But it would have to be, because they're so resource intensive, they'd have to be few and. Go ahead.
So I have can I go? Thank you. I have a follow-up question, actually, so thank you for that segue, Gail. And that is the extent to which you feel like you can, implementation is inextricable from reimbursement, as far as I'm concerned. And, the evidence, whatever they call them, evidence practice centers or whatever, have some sway over what is reimbursable or covered in healthcare. And one of the biggest examples recently to me of sort of the failure, the bully pulpit that government has is the research on hepatitis C, which has absolutely supported the use of certain medications over a very short period of time with the least side effects, with close to 100% cure rate. But the failure of insurers, including public insurance as well as commercial insurance, to cover that because it's more expensive. Lower the prices. So, so how then, lower the prices, but in order to lower the prices, there has to be some kind of intervention around that, because they're not just gonna lower the prices. And so, for example, if AHRQ says this is something that absolutely we wanna encourage implementation of, but providers, but patients are not gonna be able to get it covered, because insurers won't pay for it, or Medicaid won't pay for it, Medicare won't pay for it because it's too expensive. So what's the point? And I've seen that happen over and over again. And the whole hepatitis C thing, we did an incredible implementation project in New York State. All these providers learned the best treatments, the evidence-based treatments for hep C. It's a huge problem. It's got all kinds of other issues connected to it in healthcare. And most of the people, most of the providers that were trained can't get their patients the coverage for the leading and most effective medication.
Yeah, so I have two comments on that. So one is I think that you're right. Obviously, policy coverage payments is definitely a feasibility implementation issue that needs to be considered. And that, I don't know if it was on my slides, but that's certainly one question we've talked about. What are the policy, what are the policies surrounding the finding, and are they favorable to implementing the findings? So that's certainly a factor in prioritizing which ones we can implement. But the other thing I would say is I don't think all implementation aspects are related to coverage. I mean, there's many out there that there could be findings. One, I don't know, it's not a great example, but skin-to-skin contact for newborns. That's one thing we were looking at recently. It's recommended by everyone. It doesn't really cost anything, but it's something that can be done, and how can you implement that finding? So there are some implementation efforts that can be done that don't involve coverage policies, and that can have impacts. So I think that there are some.
My next, okay. Annette Barcon from the National Breast Cancer Coalition. I had a question on a comment that you made, Lelia, about sort of throughout this comment about advocates versus patients and stakeholders and so on. And you mentioned that advocates may be people who have stronger opinions and so on versus patients. And I wondered about that comment, and I wondered where that came from. And are you assuming that patients don't have opinions? Are you assuming that advocates are biased? And my other question is, so how many did you distinguish between what you would call patients versus advocates? Also wondered about the criteria. I know that PCORI's been working on criteria and some training around patient advocacy, because in our 20 years of training, doing science training for advocates, we really feel that educated advocates are not only can contribute in a much more meaningful way, but they also are looking at the issues in a critical way and in an unbiased way, as a matter of fact, but from the patient point of view. So.
Thank you so much. It's such a great question. And it was really interesting to me because in my data, the researchers did not talk about advocate versus sort of lay patient as much as the patients that I interviewed talked about it. And I did distinguish between people who identified as a patient representative or advocate and those that consider themselves sort of not an advocate, not affiliated with any advocacy organization. And it sort of was cut down the middle with some patients feeling like you really needed someone who was from the outside, who didn't have medical training to come in because they might point out blind spots. But there was also, of course, the view that it sort of was unfair to a patient to throw them into an environment where they're expected to contribute on an advisory group without training on research methods and study topics. And I think the NBCC lead training is a great example, and some of the people I interviewed had done that, and they really spoke about how that was key to their being able to provide feedback that was constructive. So I think it's something, researchers talked about having a representative patient, and to me I felt that what does that even mean, to have a representative patient? I think you need to have a diverse set of patients that you engage, and patients who have different experiences with the condition under study in order to get the sort of views that are going to be representative. But I don't think you can know ahead of time necessarily what a representative patient is going to look like. So I thought it was interesting that researchers kind of didn't participate in this discussion, but I completely agree with you. I think that there definitely has to be training for patients to be able to participate, and I didn't mean to imply that advocates have a bias of any sort. But it was interesting that there was sort of a divide among the patients about the quote-unquote ideal kind of patient to engage.
I wanted to make a comment to Stephanie and Lily, and this is about the issue of implementation. And one of the things that PCORI has been pressing in terms of patient engagement is the notion that when you have people who are engaged at the beginning of a research project, and particularly patients that are representing groups, that they can then take that information, if they're involved in developing it, it's answering the questions they care about, they can take that information back out to their community members can go into their physicians and it's ask your doctor about, sort of turned on its head without pharma driving it, but rather it being driven from patients who've been involved in research. So I wonder if either of you have given any thought to that.
Yeah, I mean, I've given a lot of thought. I agree completely. I mean, I think that's been our theory, and I guess, I don't know how much it's been tested or looked at it, and that's kind of why we have this evaluation aspect into our recent initiative, because with our evidence-based practice center program, that's what our questions are derived from the public. They're so I'm just kind of talking about different things, but our process for doing a systematic review is that we receive nominations from people who we hope will use the evidence in the future. And so we've started to look at some of that. Are the people who nominate, do they use it, like usually it's a guideline group, do they use it in their guideline? And I don't know that it's not 100%, and I guess it goes back to Deb's glass half full, glass half empty. I'd say it's about probably, I don't know, maybe somewhere in the middle there. So ideally, yes, those who nominate and those who are involved will use it. We've had trouble getting that data and finding out whether people really do use it and are invested. We get little anecdotes here and there, but I'd love to find a way to really look at that systematically, and we're trying to do some of it, but incomplete data. But yes.
And just to add briefly, you know, when I asked researchers why they were engaging patients, they said one of the reasons they said was to help with dissemination. And I think that that's sort of another thing that we need to study. Unfortunately, the timing of my study, the projects weren't totally complete at the time I interviewed them. But I also think this ties into the previous question about thinking about the kinds of patients you're engaging. And if your goal is to help with dissemination, you definitely want people from patient groups and advocacy organizations there, because they're going to help you, spread the information out.
All right, thank you everyone so much for your questions, and thanks to our panelists for your presentations.